now?
Yes, doctor. We can see.
Okay, so we will go to last slide. We see here. Okay, this normal appearance of the mitral valve apparatus, chordae, papillary muscle, and chordae attached to the anterior leaflet, posterior leaflet. And this is now the fibrotic mitral valve after rheumatic fever. You can appreciate here a severe fibrosis involving the valve leaflet, fusion of the commissures. And here you can see this very important finding, which is pathological finding of chronic rheumatic mitral stenosis, which looks like candle wax appearance. And this is, we called before, if you will do echocardiography and you will see the mitral valve orifice, it looks like fish mouth. And we call it as, in short axis view, fish mouth deformity. And if you will compare this in short axis and fish mouth, it's very close and very similar. So this is opening of the mitral valve in mitral stenosis. So rheumatic mitral stenosis increase the risk of left atrial and the left atrial appendage thrombus, which can lead to systemic embolization and catastrophic embolic stroke. And this is the left atrium and left atrial appendage thrombi here in this view. And this is the effect of the left atrial thrombi. The patient may be presented by systemic embolization in the form of renal infarction or splenic infarction. And this is real case for patient who presented by rheumatic heart disease atrial fibrillation, and he developed a massive ischemic stroke. And this is MRI for the same patient. And this is very interesting case, rheumatic heart disease, mitral stenosis. And you can appreciate here post-mitral balloon replacement. And you can appreciate here the ring and the movement of the prosthetic mitral valve. This patient developed acute MI, and if we'll appreciate here, in the left main, there is a huge left main thrombus, including the left main. This patient developed cardiogenic shock, not due to mitral lesion, but due to systemic embolization from left atrial thrombus while the patient on anticoagulation. Definitely, we pushed this patient to the cath lab and we did thrombus aspiration, and you can see now the aspiration catheter moving from the left main to the LAD, and we did successful thrombus embolization with some distal embolization in left circumflex, and the patient was saved after this thrombus aspiration. Role of echo in rheumatic mitral stenosis. You can measure the mean diastolic gradient across the mitral valve to check the pressure half time, and by 2D you can get full assessment of the mitral valve area and to check the pulmonary artery pressure. And this is essential component for diagnosis of mitral stenosis, not only the diagnosis, the assessment of severity, because you know in mild to moderate we can leave the patient on medical treatment, but in severe mitral stenosis we can proceed for balloon mitral valvuloplasty or surgical commissurotomy if there is contraindication to balloon mitral valvuloplasty. Severe mitral stenosis definition: if the mitral valve area less than 1.5 centimeter square, or mean diastolic pressure gradient across the mitral valve by echocardiography more than 10 millimeter mercury. And you can appreciate here on the right side the aortic pressure and mean pressure, and the blue area here represent the diastolic gradient across the mitral valve. Here it was significant during the hemodynamics in the cath lab. Also, we can get some data by echocardiography in the form of assessment of left atrial size, left atrial thrombi or not, and if it's not possible by transthoracic, the transesophageal echo here, it's highly sensitive to detect left atrial thrombi, or left atrial appendage thrombi. Also, you can assess if there is associated mitral regurg or not, because it will make difference in the management strategy. If mitral stenosis associated with grade 2 mitral regurg, so here no role for balloon mitral valvuloplasty, and you have to send the patient for the surgeon to do mitral valve replacement. Also, one of the most important echo finding to assess the RV size and function. And this is the forgotten chamber. Most of the people, they are concentrating about the mitral assessment, left ventricular assessment, but they are forgetting to assess the RV function and diameter. And this is very important in patients with mitral stenosis. Also, you have to assess the tricuspid regurgitation, because if there is significant tricuspid regurg with dilated tricuspid annulus, so this patient, he need definitely tricuspid valve repair with mitral valve commissurotomy. Mitral stenosis, secondary effect on the left atrium, you can appreciate remodeling in the left atrium. And there is two remodeling in the left atrium. If there is dense fibrosis with a small LV, this patient, he developed elevation of left atrial pressure, and he can develop pulmonary congestion and pulmonary edema. In some cases, the left atrium, it will be dilated, not small or hypertrophied. And this case, the mean left atrial pressure, it will be low, and the pulmonary congestion, it will be low, and the incidence of pulmonary congestion and pulmonary edema, it will be very low, despite the patient have severe mitral stenosis. One of the most important tips during assessment of mitral stenosis, if you will do echocardiography and you found the left ventricle, it's dilated dimension and volume. If left ventricle dilated in mitral stenosis, so you have to look for another etiology rather than mitral stenosis. You have to look for associated aortic regurg or mitral regurg or coronary artery disease, because normally in mitral stenosis, the left ventricle is small and the left ventricular function, it will be normal. But if you will found during assessment of mitral stenosis, left ventricular dilatation with increased left ventricular volume, this three possibility should be ruled out: aortic regurg, mitral regurg, underlying coronary artery disease. What about if you will do echocardiography and your assessment showed mitral stenosis and you found left ventricular hypertrophy, not dilatation, very thick left ventricular wall? Here you have to look for three possibilities: aortic stenosis, chronic hypertension, or coarctation of the aorta. And this is very important, because normally there is no LVH in patient with mitral stenosis. If there is LVH in patient with mitral stenosis, rule out aortic stenosis and rule out chronic hypertension and look for associated coarctation or not. What are the requirements of balloon mitral valvuloplasty? Definitely, we need well-trained intervention cardiologist who is highly trained in the structural heart disease, well-trained echocardiographer, and the INR of this patient, if incommodant, should be less than 1.5. Transthoracic and transesophageal echocardiography should be available in the cath lab. Pericardial drainage kit should be available, because we are performing septostomy and the needle may injure the left atrium and can lead to pericardial effusion and cardiac tamponade. So proper selection for who is candidate for balloon mitral valvuloplasty, definitely according to the guideline, any patient with severe symptomatic aortic stenosis or severe symptomatic asymptomatic aortic stenosis with positive exercise test for dyspnea and chest pain and hypotension. One of the most important finding by echo to check the valve morphology by Wilkins and Abscal score. So if the score less than 8, so the anatomy favorable for balloon valvuloplasty, so you have to go to balloon valvuloplasty if there is no mitral regurg. If the valve morphology, I mean the Abscal score more than 8, so the anatomy here, it will not be suitable for balloon valvuloplasty. And this case, you have to send the patient to the surgeon to do mitral valve replacement, either by prosthetic or metallic valve. As regard the vascular access for balloon mitral valvuloplasty, we are using the transvenous, which is antegrade approach via right femoral vein, then common femoral vein, then inferior vena cava, then right atrium. Then we will do septostomy to cross from the right atrium to the left atrium. Then we will dilate the septum. Then we will go to the mitral valve. Another approach, which is obsolete now, which is a retrograde approach using femoral artery, aortic valve, then from LV retrograde to the mitral valve, then you will do the balloon valvuloplasty. But the commonest and 100% of the cases now, they are performing transvenous, which is antegrade approach. One of the most important tips and tricks in mitral balloon valvuloplasty to do septostomy, right septostomy. And to do it, you have to look for the fossa ovalis in AB view. This is on the right side of the screen. You can appreciate the brachym pro needle on the interatrial septum, and there is some contrast injected via the brachym pro needle, and you can see a staining of the interatrial septum at the site of the septal puncture. So by performing this septostomy, you have to have Mullen-Cheese and dilator, and you have to have this brachym pro needle to do right septostomy in the fossa ovalis. What the balloon choices? We have a double balloon technique. There is two types, Mansfield over 2 wire, so each balloon on one wire, and another one which is multi-track balloon, 1 wire carry 2 balloon. The second one, which is single balloon technique, and this is the famous one, which is Inouye technique, and this is the steps in mitral valve dilatation. You have to put the balloon, half of the balloon in the LV, middle of the balloon in the mitral valve, and the distal end of the balloon, the proximal end of the balloon in the left atrium. And you have to inflate the distal end in LV first, then you will pull the balloon at the orifice of the mitral valve, then you will inflate the proximal, and you can appreciate here the waist of the balloon inside the mitral valve orifice, and then full inflation until disappearance of the waist, which indicate commissural splitting and opening of the commissure, which indicate successful balloon dilatation. And this is the effect of balloon dilatation on hemodynamic. If you can see here on the left side of the screen, the red area on the left side, this is the diastolic gradient before balloon, and this is in the middle. You can appreciate there is significant decline in the red area, indicating reduction in the mean gradient across the mitral valve. And the last one on the right, there is no any diastolic gradient between the mitral, between the left ventricular in diastolic pressure and mean left atrial pressure, which indicate successful balloon dilatation to the mitral stenosis. When to stop dilatation? If you get an area 2 centimeter or more, no left ventricular to left atrial gradient, I mean diastolic gradient, came to 0. If the patient developed mitral regurg, so it's enough to dilate even if there is a residual gradient. And in angiography, if you will see the waist of the balloon, it's open, so this is indication of commissural splitting. If we need to do another dilatation, no. If you will get mitral regurg grade 2, don't do dilatation, even if there is residual gradient, because if you will do another dilatation by increasing size of the balloon, definitely the mitral regurg, it will be increased, so will it change the pathophysiology from mitral stenosis to mitral regurg. So can we do this procedure by the echo? Yes, we can do it by the echo, and we did some cases transesophageal guided, especially in the pregnant lady, and we don't like to expose the baby in pregnant lady during the balloon valvuloplasty by radiation. And this is the steps. You can do septostomy guided by the transesophageal echocardiography. This is, you can see the tenting. The tenting, this is the tip of the brachym needle while we are trying to puncture the interatrial septum using by atrial chamber view by transesophageal echocardiography in the cath lab. And this is a real case. This case we did before. And this is the steps of dilatation. You can appreciate here on the left side of the screen, the balloon non-inflated, and in the middle, the balloon inflated half in the left ventricle, half in the left atrium, and the middle of the balloon in the mitral orifice. And on the right side of the screen here, full inflation of the balloon with commissural splitting, anterolateral and posteromedial commissures. So I will present two very interesting cases. Actually, this is the first case I did here in the kingdom. She is 38 years old Indian lady. She was living in Mecca, and she was referred for assessment of valvular lesions. We did for her echo, transesophageal echo, and we found severe rheumatic mitral stenosis. And the valve morphology, as I will see you here now, less than 8, and she is severely symptomatic despite she is in diuretic therapy. This is her ECG. You can appreciate RVH with bipulmonal and a little bit right axis deviation. And this is her echocardiography. You can see in short axis the fish mouth appearance of the mitral orifice and the mitral valve area less than 0.7 centimeter square. And on the right side upper panel, you can see the mean gradient by the echocardiography across the mitral valve. And this is associated tricuspid regurg with pulmonary hypertension. And on the right side of the screen here, you can appreciate normal left ventricular dimension and function in this lady. This is transesophageal echocardiography, and it's mandatory to do transesophageal echocardiography to assess the thickness of interatrial septum, to assess the left atrial appendage, and it's clear here, no left atrial appendage thrombi, and there is no left atrial thrombi, and only finding here by transesophageal echo, heavy smoky shadow in the left atrium indicating stagnation of the flow, but there is no thrombi. And the morphology of the mitral valve here, we give a score less than 8. So this is favorable for balloon mitral valvuloplasty. Here you can appreciate, this is a procedure in the cath lab, the guide wire in IVC, and from the IVC you can see here right atrium, then superior vena cava. Then we will put, this is the Mullin dilator, and inside the Mullin dilator, the Brackenbra needle, and you can appreciate here we inject in contrast, and this contrast opacifying the left atrial appendage and the left atrium. Now the Mullin dilator across the interatrial septum in the left atrium. Then we will push, we will check the mean left atrial pressure, and you can appreciate here the mean left atrial pressure. It's 30 millimeter mercury, and the left ventricular end diastolic pressure of this lady was 5. So the mean gradient, diastolic gradient across the mitral valve, it was 25. So this is the NV looped wire across the interatrial septum, and we will do now very important step for the mitral balloon valvuloplasty, which is septal dilatation using this 18 French septal dilator. So after septal dilatation by 18 French dilator, we will advance. This is the NV balloon. So now the balloon across the interatrial septum in the left atrium, then we will put a stylet in this NV balloon, and by this stylet you can direct the balloon inside the left atrium across the mitral valve in the left ventricle. Here, half of the balloon in the left ventricle and half in the left atrium, and we will inflate now the balloon, the distal end in the LV first. Sorry, this is hemodynamic, left ventricular end diastolic pressure 5, so the diastolic gradient 25. So this is the distal inflation of the distal end of the balloon in the left ventricle. The waist here, you can appreciate the orifice in this waist of the balloon. Still, there is waist. If there is no waist, so this is considered to be non-successful. So what we will do another inflation until complete waist disappearance. Now, The posteromedial commissure completely separated, indicating fully separation of the commissure, but still the anterolateral commissure, still there is residual waste. But fortunately enough, we checked the mean left atrial pressure, it was 8, and left ventricular end diastolic pressure was 8. So there is no diastolic gradient across the mitral valve, and we are satisfied by these results, and we consider this technique successful balloon dilatation for severe symptomatic mitral stenosis without any mitral regurg. This is the echo, significant increase in the mitral valve area, 1.7 post balloon, and before the balloon it was 0.7 centimeter. The mean gradient decreased to 5 millimeter mercury, and significant reduction of tricuspid regurg, and significant decline of the pulmonary artery pressure. Last case, 16 years old Yemeni guy, rheumatic heart disease, severe mitral stenosis, and you can appreciate here the ECG classic pictures of RV strain, RV failure, RV hypertrophy, and right axis deviation with prominent R wave V1 and V2. Echo, you cannot even, the mitral valve not opened at all. The area 0.4 centimeter. The mean gradient 30. Mean gradient 30. This is incompatible with life. And severe tricuspid regurg. And I can tell you the pulmonary artery pressure of this guy around 100 millimeter mercury, exceeding the systolic, because the systolic pressure of this patient was 90. Look for the left ventricle here. The left ventricle here, it's normal dimension, but reduce the function. And the explanation here, there is no stroke volume coming from the left atrium to the left ventricle. So we call it as disuse atrophy or disuse decrease in left ventricular function. Transesophageal echo, heavy smoky shadow, no left atrial thrombi, and you can appreciate the moderate degree of mitral, moderate degree of aortic regurg, and this is to explain why the left ventricle it is little bit dilated. Again, guide wire in the IVC, right atrium, SCVC, then the Mullen dilator in the SCVC, then after septal puncture, contrast in the left atrial appendage. Then we'll check the mean left atrial pressure, and the mean left atrial pressure was 30 millimeter mercury. And then we crossed the interatrial septum by the Inouye wire, and we dilated the septum by 18 French Inouye dilator, frequent time. Then after proper dilatation, we crossed the interatrial septum using the Inouye balloon. Then by stylet, we crossed the mitral valve and we put the balloon in the left ventricle. Then we will check the left ventricular end diastolic pressure. It was 4, so the mean gradient 25. Then we inflated the distal end of the balloon, proximal end, and here you can appreciate from one inflation only, there is complete separation of anterolateral commissure, posterolateral commissure, with decline of the mean gradient to 5, left ventricular end diastolic pressure to 5, no diastolic gradient across the mitral valve, no mitral regurg, and this is successful balloon dilatation, and the patient markedly improved and discharged home. This is our experience. We did 25 patients with severe symptomatic mitral stenosis, 15 female and 10 male, the age 35.3, and the age, as this is a distribution, majority female and the minority male. And this is the nationality. We have a different nationality for this patient. The majority of this patient are Yemeni patient. And this is the mitral valve area before and after the procedure on all 26 patients. The mean area before the procedure, 0.8 centimeter, increased to 1.7 centimeter, which is a statistical significance. Mean gradient in all patients was 16 millimeter mercury, and after the procedure 5.8. This is significant decline in the mean left atrial pressure. Pulmonary artery pressure was 57.8, after the procedure 36.8, which is significant reduction in the pulmonary artery pressure, assessment of hemodynamics immediately before and after the procedure during the cath lab. The mean left atrial pressure was 19, after the procedure was 3.1 millimeter mercury. Post-procedure, 2 patients showed increase in mitral regurg severity from 1 to 2, but no patient developed grade 3 mitral regurg, and 1 patient developed ASCD because of the septal puncture, and this is left the conservative treatment because it's mild shunt. So by end, I'd like to thank you all for attending my talk, and we are ready to hear and to see any comment or to ask any question from my colleague. Thank you so much.
Do you see any difference in the grade of mitral, the rheumatic heart disease? You see, a lot of them seem to be isolated to the mitral valve and didn't so much involve the tricuspid and the aortic. Do you think it's related to the vaccination programs that have been going on in these countries, or?
Actually, during the COVID-19, as you mentioned, there is significant decline in the number of the cases reaching in coronary artery disease, mainly STEMI patient, 40%. But in valvular heart disease, we cannot see over the last 2 years single case of rheumatic heart disease. And now we are facing mitral regurg of ischemic etiology or dilatic cardiomyopathy, sclerocalcific aortic stenosis in elderly, and this is degenerative aortic stenosis, but we cannot see a lot of patients with rheumatic valvular heart disease for the meantime.
Any further questions from the floor? We have very silent audience.
I presume the people who came from, say, Bangladesh and India and stuff, they would have been working immigrants. Would they not have had a medical assessment on their way in to pick up some of these things?
No, there is no any clinical assessment. They are only performing some tests like virology for mainly for hepatitis and for HIV, but they are not doing an clinical or physical assessment for any disease. So the only concern, including virology and for the meantime for COVID-19, but they are not doing any physical or assessment for structural heart disease or coronary artery disease for anyone who want to come to work in Saudi.